Thank you very much, Dr. Paget, for this wonderful presentation. I just wanted to share that Dr. Paget is Physician-in-Chief Emeritus with the Department of Medicine, Division of Rheumatology at Hospital for Special Surgery. He serves as the Joseph Ruth Professor of Medicine at Weill Cornell Medical College and is Director of the HSS, Hospital for Special Surgery, Rheumatology Academy of Medical Educators. We're so proud of you, Dr. Paget, and it's such a pleasure to be your colleague and your friend.
I've had many iterations of this talk over the years. I find it my most important talk because what's so key for people who have some type of inflammatory problem that they deal with on a regular basis is to be sure that they're communicating well with their doctor, giving doctors information and the doctor giving them information. And the title is Rheumatology Decision Making. Are you thinking what I'm thinking? So it's in any interaction you have in your life, the fact remains that you have to know the person that you're dealing with, and you have to know what they mean when they say certain things. And they have to know what you mean when you say things. And only in that way can this two-way communication enable appropriate decision-making and appropriate making decisions about therapy and what's going on in your life. Next slide. So please remember this. This is key. Science, like in institutions like ours, has assured tremendous improvements in the care of every aspect of your SLE. Doctors, in partnership with you and other consultants, have learned to strike the right balance in controlling lupus and avoiding drug side effects. The patient-doctor partnership and communication are your keys to a healthier future. Next slide. I really have exciting news about new and effective FDA-approved drugs for the treatment of lupus. Look when the last time the FDA approved a drug, in 1955, approved antimalarial drugs, hydroxychloroquine or Plaquenil, which is an extraordinarily important drug for the treatment of lupus. In 2011, the first targeted drug to treat lupus was FDA approved. It's called Benlysta or belimumab. Now, this is a monoclonal antibody made in a test tube against B lymphocytes, which are the lymphocytes that are important in the immune system in eventually developing autoantibodies, like an ANA would be one that you would know. Benlysta can be given subcutaneously weekly or intravenously monthly. Almost as important, in 2020, Benlysta was FDA approved for the treatment of lupus kidney disease, often along with other types of medications that may be used for kidney inflammation, such as Celsep or rituximab. Benlysta for that treatment is a weekly or IV monthly. Last year, Safnello and anifrolumab was FDA approved to treat lupus as well. And this is a monthly intravenous medication, which targets interferon. Interferon is a pro-inflammatory chemical that's produced by immune cells. Peggy Crow here and many other people around the world have given their whole life to studying this particular inflammation chemical. And God, thankfully, the FDA has approved this drug. And almost as important, voclosporin was just FDA approved in 2021 for the treatment of lupus kidney disease. So there's a whole new armamentarium. It's no longer the same old, same old. And this should give you a tremendous amount of relief to know that on many levels, whatever the issue, we have a good therapy that's generally well tolerated and effective. Next slide. So let's talk a little bit about the patient-doctor relationship. Next slide. These are realities related to the doctor-patient relationship. First of all, medicine is all about you, the patient. You deserve the best care, period. While the power differential seems to be large, it is. You are the powerful one. Please keep that in mind. Next slide. What is a good doctor? People ask these kinds of questions. You know, you try to find out from friends or people in groups like this, what your doctor's like, how do they respond to you, how do they treat you, is their office kind? Well, you have to find a good doctor who cares for you and about you. They're empathetic, which means the capacity to recognize and to some extent share feelings such as sadness or happiness that are being experienced by you and perhaps your family or your loved ones. A good doctor should engender trust. They're able to communicate. They speak to you, not at you. And they run an effective and efficient office that's up to date technologically, including electronic medical records that go across various hospitals and also treatment. Next slide. A good doctor works well with the staff and is respected by them. The doctor is responsive to all of your needs at any time. And if they're not there, somebody will be covering them in order to make sure that your care misses nothing. They seem smart, well-trained, and up to date. And they should be board certified or recertified. The American Board of Internal Medicine certifies doctors for general internal medicine and also for rheumatology. I've been on the committee in the past where we make board examination questions to make sure that doctors know up-to-date information about what's going on in lupus. Next slide. What are some of the realities related to the doctor-patient relationship? Or we could just as well make it the patient-doctor relationship. You should be treated just as a doctor would treat his or her own family. Remember, this is a special relationship and thus needs, as all relationships, constant work, honest communication, trust and mutual respect, compromise, and understanding. Next slide. What are the doctor's responsibilities? Next slide. They need to keep an open door of communication. The doctor has to respect the patient, offer emotional support, be an advocate, recognize that care is a partnership. It's a two-way partnership. Assure that patients are satisfied with their care, either related to you as the doctor or the office or the hospital. Any part of the structure needs to be appropriately and kindly responsive to you and your problems. The doctor needs to develop an office and a care environment that's sensitive, supportive, caring, responsive, safe, and private. Privacy is important. Next slide. The doctor needs to keep up to date on medical information and knowledge and the modern care of information, as I mentioned, board certification, and there's something called continuing medical education. We can't stay like we were 20 years ago and expect that we can give good care. We have to keep up. In an institution like this, which is an academic institution, we're constantly updating information so that we know to the day what the best treatment is and what the potential problems are. Doctor needs to review patient medications regularly. Which of you stopped? Which of you not stopped? We need to educate you about your illness and the medications used for it. Minimize waiting. Your time is as important as mine. Return calls promptly. Appreciate the medical costs and minimize them. That's a key thing. And we've had situations where a patient cannot afford a medicine and they start flaring and they go to the emergency room. And that's a shame. And either through the hospital or social work or just a general concept of best care, we should be able to get you an appropriate, effective medicine that's safe, that can improve your life and control inflammation. I need to appreciate medical costs and minimize them. And I need to understand you and your life and your family and your significant others. If I don't know who you are and the structure around you, I'm not giving you good care. Next slide. I have to be knowledgeable about the current realities of the healthcare system, which is always changing and complicated. What these realities represent to the patient and their specific illness and financial state. How to help you navigate through the complexities. And that's what I'm for, that's what social work is for, that's what the hospital's for. Next slide. I need to establish a process by which you that available to respond to problems, discussions, and prescription refills. I need to be available to you when you need it. That could be through phone messages, officer answering service, which are the time-honored measures. You can fax, more modern and universally available. Email, now available 24/7 via My HSS portal. And while you may not be up to date on the use of computers, perhaps your family is, but it's really important. I'm checking My HSS every hour on the hour, and often around the clock if I can. I want to know up to date what's going on, so you don't feel that there's a lapse in your care. Some doctors will give out cell phone numbers or calls for text messages. Note that regular email and text messages are not encrypted or protected. My HSS is encrypted and is protected for your good. Next slide. Doctors' expectations regarding these methods of communication. I just want to give you the general concept. You should be short and to the point, and that's best. But that's not always feasible or appropriate. If you need to say more, you should be able to say more, whatever the mode of communication you choose. Use the method that befits the problem. It's your call. You know what's going on. You know how you feel. Emergencies should be addressed through 911, emergency rooms, the doctor's office, or answering service. And you can also email through My HSS. There should be no lapse in your ability to communicate either to your doctor or the person covering for them. And that person covering for them should have as much knowledge and experience about your problem as your doctor does. Next slide. So what are your responsibilities? It's a two-way street. It's a relationship. Next slide. Honestly share your feelings. Respect the doctor, but realize that you don't need to accept poor treatment. No way. Help your doctor be your advocate. Accept your important role in the partnership. Be knowledgeable about your health and your medication. And be an informed consumer of medical care. And if you have trouble doing that, either I or our support systems here can help you do that. Next slide. Very important. Know your medicines, the doses, the reasons for taking them, and the potential side effects. So when you call the doctor, you'll be able to give them that information. Your doctor may know about it, but the covering doctor may not. Keep an updated list of your medicines with all these aspects. Be sure to tell your doctor what medicines you're currently taking, including all prescriptions, over-the-counter, health food medicines, and complementary medicines and forms of treatment. Tell your doctor which medicines you've stopped, because if you don't, he or she may incorrectly believe that you've been taking it and it's not working. Next slide. Report symptoms accurately and in a timely manner. What, where, when, and why. Just think about these 4 W's so that you can give the information quickly so the doctor understands the entire situation in a quick moment. Give feedback about your care. Talk to your doctor. There's an ombudsman in the hospital you can go to for privacy. But don't just accept bad care or lack of responsiveness on the doctor's part, because you don't deserve that, and it's their job to do it. Be accurate and assertive with messages. Next slide. It's important that you keep a chronology of your medical history. Maintain an up-to-date, detailed time chart that includes all pertinent information regarding your health care, beginning with the last time you were perfectly well and ending today. And I'll invariably ask a new patient, tell me when you last felt perfectly well and bring me up to date. I need to know the whole picture. This can be done by hand, writing it out on a piece of paper, or using a Microsoft Word document, table, or an Excel spreadsheet, whichever is easiest for you. And you should keep updating it all the time, so both you and your doctor or doctor's coverage or other doctors that may be consulting can have the information in a timely manner. Next slide. So this would be a typical kind of sheet. You can see the date on top, problems, doctor, tests, medicine, hospital, outcome, note. So this patient on June 2009 developed joint pain and came to see me. I did a few blood tests and I put the patient on an anti-inflammatory medicine. That was done at Hospital for Special Surgery. And what was the outcome of that? The person was better, the patient was better. However, you noticed, you see in the note part in the upper right, the staff was mean. And these types of notes are very important for you to keep over time so that it will remind you of what's happened. And if there are issues, you can show people this. Next slide. You need to let the doctor know who you are personally. Communicate to the doctor about the cost of medicines, medical care, and the problems you're having with the cost and your insurance. Insurance today is very complicated in this change in the financial environment. And my secretary spends much of her day trying to work with these insurance companies who try to get out of paying as much as they can, but she doesn't take anything from them. She's your advocate, as your doctor's secretary should be as well. We understand the issue, how frustrating it is to wait an hour or two on the phone. Let your doctor know how you feel and whether you're taking your medicines. They're not mind readers. And by the way, neither are you. You got to talk. You have to communicate. Be able to get a feel for the doctor's style and approach to care. If you're unhappy with your care, say so. You can tell them face to face. You can send them something. Or if you're uncomfortable about it, the hospital has mechanisms by which you can direct your annoyance. And I can tell you something, the hospital is immediately and completely responsive to that. Next slide. Communication etiquette. Whichever mode communication you use, you define the speed with which you need a response and the type of response. If you're having an emergency, the doctor should be getting back to you quickly. Be respectful of the staff and the doctor's time, but in the end, this is your health and your call. Next slide. Communication etiquette. Email should, as I said before, be via my HSS because it's safe and encrypted. That means nobody else can get into it. If you send it to my HSS email, you may have it. It is not safe. People can get in there and see what's going on. Think first about whether messages after 5 and on the weekends are necessary or can wait until the next day or Monday. If not, and you need them now, now is the time they should respond. Be as short and succinct as you can, because the doctor may have hundreds of emails and will likely respond faster to the shorter emails. That doesn't mean they should get away with responding, but that's just the reality of one's life during the day. Don't trail multiple emails below the current one, because the doctor will likely photocopy it for the chart. Next slide. You need to advocate for yourself. Communicate your frustration about the doctor or his staff via face-to-face interactions, email, letter, fax, or phone conference. Remember, your happiness with your care is paramount. If you're not pleased, you can change your doctors without fear of retribution. Next slide. Remember, medicine's all about you, the patient. You deserve the best care, period. And as I said, while you think the power differential seems large and may be lodged in the doctor, you are the powerful one. The system will be responsive to you and your concerns. Next slide. Let's talk a little bit about medical decision-making. Next slide. In the end, like everything in life, it comes down to a cost-benefit decision. The problem is that the physician and the patient may value the costs and benefits differently. Medications like Plaquenil, methotrexate, steroids, and some of the other newer medications. To me, these drugs, while they have potential side effects, can be monitored well to assure effectiveness and avoid side effects. To the patient who Googles it, it may seem like, are you serious? Why would he be giving me this toxic drug? And you should let them know. In the end, the decision is yours, but you try to work it out with the doctor who can give you both sides. Next slide. The rheumatologist's perspective on the available SLE medications. And I've listed many different ones. Antimalarial drugs, low-dose steroids, mycophenolate, azathioprine, and some of the newer intravenous medications. Next slide. Now, these have increasing power against inflammation and increased potential side effects. However, if I make a decision in any one of these lists, either the ones with more potential side effects or the ones with fewer, I'm making that decision on your behalf because I know everything about you, everything about your life, your past experience with medications, and what you need to get to where we need you to go, a healthy state. Next slide. What about the patient's perspective on all available drugs? Next slide. Many of them think that all drugs have problems. And there are many people who come from families where they're just very anti-drug, anti-therapy. And that's your right. But I need to talk to you about the pluses and minuses and tell you why I've chosen something for you, specifically for you, with all of my cumulative knowledge over your lifetime. I'm going to try to make the right decision. You make the final decision. Next slide. Here is my thought process. The patient has a problem that needs to be treated, such as a skin rash, fever, arthritis, weakness. I need to make sure that the treatment chosen befits the intensity and severity of the problem. I always teach my fellows, and you, what's the size of the fire? If you have a little candle with a flame on it, you can squirt that out with a squirt gun. If the house is on fire, that amount of water is not going to do anything. You need something stronger. With joint inflammation and skin rash, I will try to use a kinder, gentler drug, like a non-steroidal anti-inflammatory medicine, topical steroids for a rash, or antimalarial drugs, sometimes oral steroids in low doses and short courses. Next slide. For more significant inflammation, such as internal organ problems, I will likely use stronger medicine because the problem is more significant. And the experience has shown that hitting it hard and early assures the best outcome. So I might use higher doses of oral or intravenous steroids, Cellcept, rituximab, or Cytoxan. These may be drugs that you know or don't know, but they're immunosuppressive drugs aimed at controlling an overactive fire from the immune system. Next slide. The question is the good, the bad, and the ugly. What is the worst bad? The illness? The medicine? Doing nothing and letting nature take its course? Given my knowledge and our knowledge in places like this about both the illness and the medicine, and you, I can come to a decision easily, but you may not want to. Next slide. Why a physician may want to use a drug. Think of these things. What am I thinking about? Is this guy crazy? Is he thinking about what the potential problems are relative to me? Well, I may think it's going to work quickly and effectively, and its cost-benefit balance is acceptable. The cost being the potential side effects and the actual costs, usually taken care of by insurance, or the benefits, getting you back to good health. I may say, well, many randomized controlled trials in the same population as you have shown that this drug is safe and effective. Long-term surveillance studies, that's over years, where you follow people to see if the drug is safe and effective, done via the FDA, the Food and Drug Administration, have shown that the study results are the same in the patients. So remember, they take 3,000 patients to do a study. And you might say, are they me? Or are they a separate group of people that don't relate to me at all? Well, I can make that decision because I read those papers and I can understand what population they're dealing with that they showed this drug works in. I may say that a milder or current medication is just not disease modifying and is not working. What does disease modifying mean? That means whatever presentation your illness, your inflammation is showing, your current medicine is not sufficient to calm that down. It's just not working. Next slide. Why a patient may not want a medicine. You may think of these things. You don't like any medicine because in your or your family's experience, the cure is invariably worse than the disease. You fear the medication more than the illness. You've heard from other patients that the drug causes all kinds of problems. You heard an ad on television about the drug that scared the hell out of you, including toxicities such as infections, tuberculosis, cancer. You know, they rapidly put these after ads. Scares the hell out of you. Now, the drug may not be out long enough, and we don't know what its true long-term side effects are in the real world. But that's my job to describe to you why I'm choosing this drug exactly for you. I'm not making a wanton decision here. I'm making a specific decision. Just think of it this way. You have a urinary tract infection. We put your urine in culture and we get the right antibiotic for you. It's called an antibiotogram. So I know the exact antibiotic that's going to work against your urinary tract infection. And I try to do exactly the same thing when I'm choosing medicines for your lupus. I'm trying to strike the right balance using all of the information I can to make the right decision for you. However, that's just the beginning. I'm following you closely behind to see how you do. Positive effects, negative effects. Next slide. How should the doctor and the patient come to a final decision? Each should give their perspective on the drug and your illness, what your concerns are, and what information you need to make a decision. The physician may give the patient reading material, and the patient can do their own homework on the internet using reliable sites. I can refer the patient to lupus support and education programs like this workshop, which we started 25 years ago. Lupus Line, Charlotte de Lupus, for a trained peer counselor or even a patient who's gone through this. Please avail yourself of these. Provide the patient with the name and number of other patients who have made similar decisions. I have a lot of patients who would be happy to talk to you about the problem they had making the decision and how either happy or unhappy they may have been. You should ask for that. Or get a second opinion. In this city, there are many other institutions that are excellent and focus on lupus, NYU and others. If you're not happy about this decision, get a second opinion. Next slide. So simpler treatment decisions, where the benefits usually outweigh the costs most times. Extra strength Tylenol, 2 twice a day, very effective. Anti-inflammatory medications like ibuprofen, naproxen, meloxicam, or topical steroids for the hand, Voltaren. Topical steroids for a rash, short courses of low-dose steroids, 10 milligrams twice a day of prednisone for 4 or 5 days could turn things off quickly with a rapid taper. Minimal side effects, if any. Local injections of steroids into joints or areas of inflammation, or certainly hydroxychloroquine or Plaquenil. Kinder, gentler medication. Next slide. What should you know about steroids? Of all medications, they are the worst bad when taken in high doses for longer periods of time. For example, 40 to 60 milligrams a day for a month. Side effects include infection risk, bone thinning or osteoporosis, diabetes, osteonecrosis, which is bone damage, high blood pressure, easy bruising, thin skin, weight gain, and mood changes. Many of you know these. They're very, very frustrating. And we try to use the lowest dose for the shortest amount of time to avoid side effects. And we often use other medications to spare the steroids, which will control the inflammation on their own without steroids. Then why in heaven's name would you ever take steroids? Because nothing brings down inflammation faster or better. Short courses, 1 to 2 weeks, low doses, 10 milligrams twice a day, are relatively safe. But alternative medicines must be added in order to control inflammation and spare the steroids. Next slide. Common drug combinations aimed at specific problems. So for milder problems, joint pain, skin rash, hair loss, fatigue, we might use hydroxychloroquine or Plaquenil, anti-inflammatories for the joints, short courses of low-dose steroids. For more significant illness that's either gone on longer or is more severe, joint pain, pleurisy, chest pain when you take a deep breath in, fever, a bad rash, could use antimalarial drugs, immunosuppressive drugs like methotrexate and Imuran, anti-inflammatory medications, short courses of steroids, Benlysta, that monoclonal antibody against B cells, or Safnello, that monoclonal antibody against interferon alpha. For more severe disease, these are organ problems like kidney involvement, we might use higher doses of pulse intravenous steroids, immunosuppressive drugs, drugs like rituximab, cyclophosphamide, Benlysta, cyclosporin, voclosporin. Now, all of these have their place in the armamentarium for the treatment of lupus. Each one is chosen because of the severity of the issue. And even if we use it, we observe it very carefully with regard to potential side effects. Next slide. So say I want to change from steroids and Imuran and Plaquenil to Plaquenil, Cellcept, mycophenolate, and taper steroids. Why am I doing this? Well, I see the current medications are not working, either to stop the inflammation or improve your function. I want to make you able to navigate through your world without restriction. Now, how do I make that decision that the previous drugs are not working? I can define it by what you tell me, what it does to you, what's the functional effect. I can do blood and urine tests and x-rays. Or the current medication may have led to side effects and is also not helping. So a switch is important to avoid further side effects and improve disease control. Next slide. A new medication may have been approved by the FDA and would be better for you than the current medicine. And I've given you that list right at the beginning to give you hope. These drugs are amazingly effective and very safe. You need to get off steroids because of the cumulative side effects. And an alternative, steroid-sparing, disease-controlling medicine is necessary. This is why I'm making this decision to make a change. Next slide. Important partnerships in care include you, your rheumatologist who knows you and your history best, and will, after discussion with you and your family, make the best treatment decision for you and your lupus. Yet we have many consultants who are extremely important to call upon when necessary. Social workers, kidney doctors, nephrologists, pulmonologists, cardiologists, dermatologists, orthopedic surgeons, neurologists, and endocrinologists. All of these are part of the care system and are brought in when necessary, when things are getting problematic or we need to assess things differently. Next slide. So I tried to give you some sense of the way in which I think about your care. And it's important for you to give me your sense about your care at any time along the way. And I'm perfectly happy to answer any of your questions.